Thanks, Rick. So my name is Micah Burns. I'm a pain management physician at Change Pain Clinic in Burnaby. I'm going to give a chat today about pain drivers and interventional treatment options. So I don't have any financial disclosures, although just to say that a lot of stuff here is AI generated. So if it's a complete sentence, it's basically AI generated. So I'm going to talk about both interventional treatment options, kind of each technique that we use, and then the actual pain drivers, like the most common things that I see for pain, like painful body parts, basically, and then how we apply each of those interventional treatment options. And I did want to just point out that pain is like a pretty complex topic. So I'm not talking about a lot of background, I'm just giving you options for interventional treatment at an interventional pain clinic. Injections are rarely the only cure, and they're always part of a interdisciplinary plan. So I think about, like, even if you think about something like a sports injury, someone injures their knee, they usually go to rehab, and maybe you get an injection to help the rehab along. It's the same way that I think about chronic pain is, how can I help movement and function come back faster? So in chronic pain, usually, though, there's more team members, because usually there's mental health and there's a lot more education that plays a role, which everyone here would be aware of at Rick's clinics, of course. And of course, there's a bit of a longer timeline by definition. So just to say, I think that our bodies are meant to move, they're meant to function in space. So treatment should be used to facilitate that movement and function. It's not just about pain relief. It's about function, and pain is one marker of that function. So here's the interventional treatment options I'm going to chat about today. So first, trigger points. So myofascial trigger points, basically just a small sensitive area within a muscle. It can cause pain. People get dry needling from like physios, or lots of doctors know how to do this. I think it's a very low risk thing to get a trigger point. So trigger points themselves, the difference between what maybe a doctor can do and what a physio can do is the needle is a bit different. So a physio needle is like an acupuncture needle, looks like a pencil tip. So it's kind of a blunt needle. So it just kind of pushes through, but does not cut. The needles that we use can inject things, which is one of the big difference, and they have a small cutting edge. So cut a hypodermic needle, which plays a role because in trigger points, often using local anesthetic can make them a bit more effective. Local anesthetic has an anti-inflammatory effect, and the trigger points themselves are like little pro-inflammatory factories. So if you can release them, you can release some things that are increasing inflammation. So you get decreased inflammation and decreased pain. And also in terms of like interventional options, they're very, they can be done very gently, very superficially. And so it's a good test to see how you do with needles, right? So like if you've never tried needles as an intervention, this is they can be kind of a test to see, are you going to get a big pain flare? Are you going to get any relief? Or is like the thought of having needles or even coming into the clinic and going through the whole process just too much for you, right? So that they're a good kind of low risk test for you. So nerve blocks. So the picture is an ultrasound on the skin, and then the picture below is kind of what you might see during a nerve block. You can see on the right of that picture by the ultrasound is the needle. So we can use the ultrasound to see
we actually don't see anything except the first slide.
Oh, shit. Sorry about that. All right, we gotta try that. Let's try that again. How's that?
Yep.
Better?
Excellent.
You missed that? All right, well, that's what trigger points look like. There you go. So nerve blocks. There you go. Better? Good. So you can see, so we look through the skin at the structures underneath the skin. You can differentiate muscles from tendons, ligaments, and nerves, especially. And so a nerve block is injecting with a needle, local anesthetic next to a nerve. And the purpose of that is to interrupt the signal the nerve is bringing back. We do this around surgery. We do it to interrupt pain signals. The local anesthetic itself lasts about 1 to 4 hours, depending on the type used. And we use these for a couple different things. So one, like repeated nerve blocks sometimes themselves can bring some ongoing relief, whereas that's variable. A lot of times we use nerve blocks to diagnose where pain's coming from. Same thing as like taking an X-ray. You want to do you can do you do a blood test. It's the same idea. This gives you an idea of what's actually causing pain as specifically as possible, right? Because you can say you have low back pain, and we'll get into this a little bit, but does that mean you have nerve pain? Do you have disc pain? Do you have ligamentous pain? Do you have joint pain? There's all these different structures that make up each body part. And so trying to differentiate between those is how we use these kind of nerve blocks. And the risks with nerve blocks are needle through the skin, which basically means there's a risk of infection or bleeding, risk of nerve damage or worsening pain. That's pretty much the same for any kind of injection we do. Needle through the skin, bleeding or infection, risk of nerve damage for a lot of this stuff, worsening pain or allergy would be another thing. So steroid injection, so kind of a cortisone injection. No one actually injects cortisone. That's just like a thing that has been passed on in our like collective consciousness for some reason for a long time. But we inject all sorts of other steroids, corticosteroids, which is the same thing as cortisol. It's like a stress hormone in the body. The benefit of doing an injection of the steroid in a certain area is you get less systemic side effects. You do still get systemic side effects, but less so. It's more concentrated in the area. So you get a targeted effect with a little bit less systemic side effects. So it's anti-inflammatory, pain-relieving medication. Takes a couple of days to kick in, 3 to 7 days. The problem with steroids is that sometimes they don't help at all, and you still get the side effects. And they last 2 to 3 months or so. So that can be pretty good. Sometimes a bit longer. And for some things, they are the treatment. But generally, you have to kind of repeatedly inject it. And you have to think about if you're injecting steroids, a stress hormone, it stops inflammation, but inflammation is also how the body heals. So you actually can kind of decrease healing in an area if you increase the concentration of this hormone in the area. So for instance, let's say you have knee pain, a steroid injection in the knee can be effective at relieving your pain. And if you're going to get a knee replacement in a year, maybe that's okay. Your knee's probably going to degrade a bit faster than it would without the steroid. But if you're going to get a knee replacement, maybe you don't care. But if you're hoping to avoid surgery, which I think should be a good goal for everybody, you should always at least try to avoid surgery, then there's usually better options than steroid for something like that, that are both more effective and often have less side effects. Steroids are often the cheapest option, however. I would say most of the stuff I do is basically trying not to inject steroid into places and instead to do other more targeted techniques that have less side effects. One of those things is hyaluronic acid. So this is viscose supplementation. It's the same thing that people put like for their face, like in their lips, that filler stuff. We put it in joints, used basically for painful joints. Like there's some evidence you can use it in soft tissue, and I've tried it a few times. I think it's okay. Hyaluronic acid is present in the joints at very high amounts, and the amount decreases as we age. So when it's in there, it acts as a lubricant. It's kind of mucousy. So it acts as a lubricant, a shock absorber, and then synthetic hyaluronic acid is anti-inflammatory. And the synthetic stuff can resist breakdown. So it's actually, you inject it and they keep finding these like more and more cross-linked ones that can stick around in the joint for a long period of time, or in your lips for a long period of time, if you want to do that. Risks are something like basically needle through the skin. You use local anesthetic and people get allergic reactions to that, but that's super, super rare. I don't think I've ever seen that. But anytime you're injecting a substance, someone could be allergic to it. It's pretty good. Like it can last 4 to 6 months. There's some studies showing that it can delay the time until total knee replacement is necessary. So it could be good for that. For some people, it can last for much longer than 4 to 6 months. And some people it doesn't help at all. Of course, that's always an issue. hyaluronic acid, sorry, extended health covers it or private pay, just to, so that's clear. Botox. So and Botox is something that is injected under the skin or around a nerve. It's then absorbed by the nerve and stops the nerve from releasing a neurotransmitter. So if that nerve is a motor nerve, you get muscle relaxation, which is what people are doing with that, with the aesthetic stuff, right? You're looking for muscle relaxation. If it's a sensory nerve or pain nerve, you get less pain. So you can put it like in a joint where there's no muscles, there's no strength coming from within the joint. So you get pure sensation decrease. It is by definition self-limiting because the nerve, it gets absorbed and then metabolized by the nerve. So it lasts usually 10 to 12 weeks. Although in joints, it tends to last something like 6 months. I got one patient who's going on about 2 years now. I did single injection, decreased the inflammation and pain in his shoulder, and it hasn't come back. So sometimes you get lucky. It's mainly used in headaches. You can use it in like jaw pain, like temporomandibular pain, or spasticity, like after surgery. I have some patients with a certain kind of neuropathic condition called CRPS. They get dystonia, which is abnormal tone in the muscles. So I use it for that. That picture up there is the preempt protocol used for migraines. So it's just a standardized protocol, which is shown to be effective in a couple of randomized controlled trials. The risk of Botox, needle through the skin, you can get muscle weakness, temporary because Botox goes away. Some people get a systemic flu-like symptoms for a couple of days. That's pretty rare. Only seen that a couple of times. In allergy. So, and it's just to say Botox is the trade name. There's a bunch of onabotulinum toxins. There's like 6 or 7 of them. And different ones have different possible allergic reactions. So Botox is super rare. Some of the newer ones, you have to be careful. Extended Health covers Botox for headache. The province in BC, I don't know why, but they will not cover Botox for migraines. They will cover CGRP inhibitors, which is a monthly injection. The province will cover Botox for things like spasticity. So regenerative treatments. So these are, the idea with regenerative medicine is, as opposed to steroids, which kind of stop inflammation and also stop healing, like stop the turnover of cells. The point of regenerative medicine techniques is to increase inflammation, increase turnover of cells, increase healing in the area. So you stimulate healing. Platelet-rich plasma, pure private pay, but it is available widely throughout BC. So I thought it was worthwhile talking about. It's a concentration of platelets derived from your own blood. So we draw blood. Different people do it different ways. We draw 60 cc's at our clinic and do a double spin technique. It concentrates 60 cc's of blood to 7 cc's, which is about 10 times the amount of platelets that's in your own blood, and then re-inject it into you immediately afterwards. Platelets have a lot of growth factors in them, stimulate tissue repair regeneration, so you can use it in soft tissue pain or injury, like ligamentous or tendon injuries. Joint arthritis has a lot of evidence in knees and hips, and some spine pain. There's some studies on that, which is pretty good. So the benefits of platelet-rich plasma are reducing pain and inflammation, although not right away, promoting faster healing. So maybe it would heal anyway, but this will happen, it'll get faster. Or if you have an injury that isn't healing, this can be a way to initiate the healing process. And it strengthens tissue where it's injected, as opposed to the steroid, which tends to weaken the tissue where it's injected over time if repeatedly injected. Risk of platelet-rich plasma, it's a needle through the skin. It's quite costly. And the area is a bit sore after the injection. It takes about 3 months to get the full effect, although you see some effect by like 4 to 6 weeks. Prolotherapy. Prolo is like proliferative therapy, so like causing inflammation. You inject a natural irritant. Dextrose is very commonly used because it's everywhere in medicine. At a certain concentration, more than 10% basically, will cause irritation in the area where it's injected because it's such a strong concentration. You inject it into the soft tissue of an injured joint, tendon, ligament, triggers the body's healing response, which promotes the repair of the damaged tissues in the area. You can inject it into soft tissue, around nerves, into joints. It causes, that's supposed to say increased elasticity. I didn't catch that. Sorry. Oh no, reduced elasticity. So it strengthens like collagen basically. When they did injections on poor little mice, and then dissected them, and their connective tissue was about 40% stronger just from the injection of 25% dextrose. So it is a bit variable of an effect. The province won't pay for it, I think, probably because of that. We don't know exactly who it's going to help, and sometimes it's amazing, sometimes no help. It's hard to predict, or you can't really predict. I think it's interesting in this like hypermobile spectrum because it can be repeatedly injected safely, unlike steroids, where you don't really want to repeatedly inject steroids. It doesn't have the same systemic side effects. And of course, steroids, as I said, weaken the connective tissue in the area, whereas the goal of prolotherapy is to strengthen. So risks, needle through the skin, so bleeding or infection, local soreness and inflammation, and rarely can cause an increase in pain. Again, just like everything that we do. The needle. Nerve blocks with dextrose, so greater than 10% concentration is like prolotherapy, causes irritation. Less than 10% does not cause irritation, but it still affects the sensory nerves in the area. So it interacts with a specific receptor on the sensory nerves, a TRPV1 receptor, kind of like capsaicin, which is a topical thing you can buy over the counter. Also treatment for arthritis or like nerve pain on the skin. Interacts with the same receptor there. So it can modulate sensory nerves, kind of turn them down, basically. So you can do like significant perineural injections, which can reduce neurogenic inflammation, which is really useful. And then hydrodissection around something like an entrapped nerve, like carpal tunnel syndrome. The new recommendation on carpal tunnel from a new review is to actually use 5% dextrose instead of steroid. It works about as well, has less side effects. And then nerve ablations. So all ablation techniques are preceded by a diagnostic nerve block. So nerve ablation is never a first step. You always do a nerve block with local anesthetic to see if you can turn off the pain from a given area, or how much pain goes away. You have to test, is the nerve that you're considering destroying or killing, burning, actually carrying pain signals or not? And you want to find the majority of pain in an area. You don't want to go through the risk of an ablation procedure for 10% decrease in pain. So generally 50% or more is the number that's generally just employed kind of in the area. It means kind of the majority of pain is coming from that area. So the patient, if they go through the procedure, should get pretty good relief and increase in function. So always a nerve block, and then I'll discuss the possible ablation techniques. So phenol ablation is the injection of phenol, which is kind of a mixture of things. It's a neurolytic agent into around the nerve. If you recognize that picture, it's a benzene ring for you chemical nerds. It basically dissolves lipids. Nerves are surrounded by lipids, so the lipids get dissolved, so the nerve doesn't work. So it can't provide its function, which is to transmit those little pain signals back. First, you inject local anesthetic, and then phenol. Phenol itself hurts a little bit. It feels kind of deep and achy. This is probably the least targeted of the intervention technique because it is a liquid that you inject, so it kind of spreads in the area. I find that if this is the one I have to, if I use this technique, it's the one that I have to repeat the most because I think it's just not as targeted in the area. I suppose the benefits are that it's MSP covered at Change Pain, like we supply the medication under MSP, but it can't be used in certain areas. It can't be used on the spine because the risk of it going into the spinal cord is too high. There's been some case reports in like third world countries where they tried it and people ended up with spinal cord injuries. So risks of phenol, needle to the skin, so bleeding or infection, allergic reaction, you can overdose on it. So you have to just not inject too much, which we never do because it's only small amounts are needed. It can be sore for about 4 weeks afterwards, which is the longest of any of the ablation techniques. So it can get into the muscles around the nerve and cause some myositis, like inflammation of the muscles. And that's usually what's sore for, it can be sore for a month. So there's also continuous radiofrequency ablation, RFL, RFA. Rhizotomy would be another thing in the spine, you'd call it that. But basically you do, you place a special needle that can conduct radiofrequency energy. You put it next to the nerve, you numb the nerve, of course. And then the continuous radiofrequency, so it doesn't go up and down, it's a continuous application of the energy. So that energy builds up in the tissue around the needle tip and heats up and destroys a small section of the nerve and the surrounding tissue in the area. Your body has to heal from that, and the nerve grows back over time. But in the meantime, until the nerve grows back, you have less pain. Well, only certain small nerves are safe for this technique, mainly sensory nerves to joints, like in the back, the knee, the hip, shoulder, that kind of stuff. If the nerve is too big or has too much motor function, you can get something called a neuroma, where the nerve kind of grows into itself and starts activating itself. And then you get chronic pain, worsening chronic pain in the area. So risks with RFL, needle through the skin, so bleeding or infection. You're applying heat, so there can be some discomfort during the procedure. And of course, your body has to heal from the damage done afterwards. You can have increased pain for a couple of weeks. Usually it'd be 3 to 4 days, and then kind of getting better over the next few weeks. And you can have some numbness in the area that's treated. Pulsed radiofrequency is kind of the softer cousin of radiofrequency ablation, PRF. So instead of continuous application of radiofrequency, it's pulse. So it goes up and down a few times a second. That allows time for the energy to dissipate through the tissue. Heat never builds up. It never gets above 42 degrees Celsius, usually somewhere around 38 to 40. So there is no heat generation, basically no tissue damage. I mean, it can be a little bit right at the tip of the needle sometimes, but it's very, very minimal, very minimal. And certainly you don't damage the nerve. It takes a couple of weeks to kick in because this actually changes the function of the nerve over time. So 2 to 3 weeks, and then usually just kind of turns down the pain. It's pretty effective, considering that there's no actual nerve damage. The risks are, of course, needle through the skin. There's never been any long-term downsides to doing pulse radiofrequency. Like there's never been any increase in pain for weeks or months, never ongoing pain, never any neuroma formation reported anyway in the literature. So it's considered extremely safe. And for people that are very sensitized, this might be something that you'd go with first. So turns down the function of the nerve without damaging the nerve. It's pulse radiofrequency. Cryoablation, similar to the radiofrequency ablation, but with cold instead of heat. Procedure is much less painful, but does take longer because you go through these repeated freeze-thaw cycles. Basically is used for joint pain, some like smaller kind of sensory nerves. Unlike radiofrequency ablation, it can be used on a few other smaller nerves, like pudendal nerve for pelvic pain or the pudendal neuralgia. And so what happens is that top of that, on that picture to the right, the top of that is a little canister that has nitrous, which is released down into those tines in the bottom, and those are closed. So the nitrous goes into the tines, it forms a gas. It does not enter the body. It stays in there. It makes the metal of the tines really cold, which forms an ice ball from the fluid in the body, which then thaws when the nitrous is drawn back up into the machine. This does preferentially destroy nerve tissue, as opposed to something like the radiofrequency ablation, which just destroys anything in the little orbit of the needle tip. And it does tend to work on smaller nerves more than motor, which are bigger. So it tends to get autonomic and sensory nerves, less motor. So if a nerve has mixed sensory and motor parts, then you tend to get more decrease in sensory and less decrease in motor. So that's what we talked about. Those are the interventional treatment options. It's not an exhaustive list. It covers basically what we do at Change Pain, I think, most community pain clinics. There's things like peripheral nerve stimulation, spinal cord stimulation, which I didn't really cover. They're rarely done in Canada, much more often done in the USA. It's very expensive. Someday Canada will be rich enough to afford more of those, but right now there's like 2 centers that do it under Healthcare Authority budget. They do not have access to a huge number of these things, and we don't have any peripheral nerve stimulators in Canada. There's one coming out soon. Government won't cover it, unfortunately. So that'll be like private pay or ICBC insurance. They can be effective. People are still figuring out the best way to use them, I'd say. So pain drivers, these are the things I'll talk about. Myofascial pain, headache, spine pain, peripheral joint pain, and nerve pain. This is just the stuff that I see kind of in my day-to-day. It's far from an exhaustive list, of course, of things that can be treated or that I treat, but it's, I think, hopefully a good piece of it. So myofascial pain syndrome, basically we talked about this, just characterized, it's a pain in the body characterized by the presence of trigger points, little sensitive areas within muscle or fascia that cause pain. They can be active, so they're always painful, or latent, meaning when you press on them, they cause pain. And basically the treatment is trigger point therapy from an interventional standpoint, right? And so local anesthetic, definitely more effective than just dry needling. And some things, like there's good evidence that doing trigger point therapy with local anesthetic is more effective in tension headaches, more effective in migraines, where there's evidence that trigger points with local anesthetic can cut headache days and pain and headache intensity. And as I said, it's a good introduction to interventional techniques. Just especially just getting a couple of trigger points like in your traps on either side of your shoulders. Very safe. You can get like an injection or 2 per muscle, tiny little bit of local anesthetic. You walk out of there feeling nice because of local anesthetic, and just see, like, do you get a pain flare from the needle going in? Are you that sensitive, or do you get a little pain flare and then feel better afterwards? Like that would be pretty common. You get a couple hours or a couple of days of increased pain and then a couple of weeks of feeling better. And for some people, though, they get the trigger points, they feel good at the time, but the pain never goes away long term or doesn't seem to improve. And that can be because joint pain feels like muscle pain. Because so basically when a joint moves, every muscle that moves the joint sends a tiny little, the end of the nerve that moves the muscle ends in a little sensory nerve into the joint. So and so when that sensory nerve is sending back pain signals from the joint, it travels along the nerve that also moves the muscle back up to the spinal cord and then the brain. And so all your brain interprets that as there's pain somewhere down there from that. It knows maybe that nerve, but it doesn't know it's the joint versus the muscle. And so what you feel is muscle pain. Let's say your knee hurts, you actually feel like maybe quadricep pain or calf pain. Because your body's not good at being specific. So if you feel like maybe you have muscle pain in an area, but trigger points aren't helping, you have to look at something else, usually the joint that muscle moves. So a little bit about headache. So just a bit of background, primary headaches are caused basically just by the headache process itself. There's no reason for it, versus secondary headaches where there's a reason for the headache originally. Tension headaches are like a pressure band-like pain. Can last any amount of time, usually bilateral. Mild to moderate pain. You can have nausea with that. That's okay. It doesn't get worse with physical activity, usually. So migraine is more severe throbbing pain, lasts at least 4 hours. Often unilateral, can be bilateral. Nausea, vomiting, issues with light, sound, or smell. So that's the difference between tension and migraine headaches. And most secondary headaches present as either a tension headache or a migraine headache, but with another reason for that headache. So treatment tends to be concentrated kind of on those ideas. So, and I just wanted to say medication overuse headache, like a rebound headache would be another word for that. Basically taking triptans, Tylenol, Advil, naproxen, opioids, anything along those lines. Opioids would be like morphine, hydromorphone, oxycodone, hydrocodone, those kind of things. If you're taking too many of those per month, you can get a whole second headache. So let's say you get migraines and you have knee pain. If you're taking Tylenol every day for your knee pain, your migraine doesn't care that you're taking it for knee pain. It's still going to give you a medication overuse headache. Not in everybody, of course, but you can get worsening headaches from taking those, even those very, very simple medications. You can start getting rebound headache. So if you're taking, basically good rules, if you're taking a medication 15 days out of the month for anything, it can give you another kind of headache, medication overuse headache. There's also cervicogenic headaches like whiplash, so pain in the cervical spine and the neck, which is causing a headache. So that's the trigger for the headaches, or one of the triggers. Temporomandibular joint pain causing headache, so that would be kind of right in front of your ear is where that joint is, or something like trigeminal neuralgia, which is a sudden severe stabbing pain, usually in the face, typically one-sided, very quick, kind of lightning bolts. So I'll kind of talk a little bit about the nerves involved in those. So this is just a drawing. This is the nerves in the head. It's obviously not exhaustive, but it's some of them. The occiput, the left side of the picture there is the back of the head, the occiput there, and the nerves there are, of course, all called occipital nerves. There's the greater occipital nerve, lesser occipital nerve, third occipital nerve. If you look at the middle picture there, it's the side of the head. There is auricular nerve. So there's one behind the ear called the greater auricular, in front of the ear to the temple, auriculotemporal. In the front of the head is the trigeminal nerve. Tri for 3. It comes out, the most peripheral branches come out above the eye and then go all the way back to almost to the back of the head. That picture on the right doesn't show it. The middle picture shows the supraorbital, the top branch of trigeminal going all the way back to the back of the head. And it comes out below the eye and on the chin. So those are the nerves. And those nerves from the front and the back of the head meet in the brainstem and form what's called the trigeminal cervical complex. So they can talk to each other at the level of the brainstem and sensitize each other to pain. So when pain is very bad in one area for quite some time, like let's say you have chronic migraine with a lot of back of the head pain that's uncontrolled and pain's quite bad, and you start to get facial pain, you don't have a new injury in your face. You just have sensitization of the trigeminal nerve due to its interaction with the occipital nerves at the level of the brainstem. Right, so the pain itself is spreading, and we can use that the other way around too, where we do nerve blocks for pain. So we can block, let's say, the occipital nerves in the back of the head, and that can reduce headaches. Or you can block the trigeminal nerves in the front of the head, can reduce headaches. But often people get more benefit combining that too. So doing one in the front and one in the back, and now you're decreasing input to the entire trigeminal cervical complex at once, and you can get more effective pain relief that way. So the big one in the back of the head, greater occipital nerve, good for so many different kinds of headaches. It's studied in migraine, tension, cervicogenic headaches. It can help with trigeminal pain through that interaction at the trigeminal cervical complex. It can help with chronic daily headaches, medication overuse headaches. And what can you do to that nerve? Well, you can do just a nerve block with local anesthetic, doing it between the muscles at the level of the occipital capitis inferior can provide 2 to 3 weeks of decreased headaches and intensity of headaches, number of headaches. You can add steroid to that, especially if someone has like migraine or status migrainosus. Doing a nerve block with some steroid in it can be useful. And then you can elongate the effect of the nerve block by doing pulse radiofrequency to this nerve. It can be effective for like 4 to 6 months on average. I have a couple of patients that I see every 4 to 6 months for various things, medication overuse headache, which they can't get off the meds unless they do this, or just cervicogenic headache, or just chronic migraines. So pulse radiofrequency can be very effective. You can't ablate this nerve. I've done cryoablation on it for one patient. They found it effective. Excuse me. But there's not good evidence for that. And you definitely can't do a heat ablation to that nerve or a phenol ablation. The risk of increased pain is way too high. Trigeminal nerve, the one in the face. So you can use it you can do a block to those nerves for trigeminal neuralgia, for migraines. And the nerve above and below the eye go back through the skull, back towards the brainstem, but they The nerve above and below the eye meet and form what's called the sphenopalatine ganglion, and they're joined there by some autonomic nerves. Autonomic nerves are involved in like blood vessel control, which is partially one of the issues with migraines is you have changes in blood vessel caliber. And so sometimes doing the very surface trigeminal nerve blocks is helpful, and sometimes getting the sphenopalatine a bit deeper and getting the autonomic nerves is more effective than the peripheral nerve blocks done just on the surface of the face. So anyway, for the trigeminal nerve, you can do nerve blocks, local anesthetic, of course, you can try steroid. You can try pulse radio frequency. It's not wonderful unless you combine it with the greater occipital pulse radio frequency. Cryoablation, I've had some success with that with trigeminal nerve. It doesn't get the whole course of the nerve, however, it's not as deep as you can. You'd have to go to a neurosurgeon for that in BC. But you can reduce symptoms by at least decreasing the pain in the face, if not deeper. Sometimes doing trigeminal nerve blocks and then doing subcutaneous dextrose, like a 5% dextrose to kind of decrease some of the neurogenic inflammation can be useful. And then Botox for something like trigeminal neuralgia. You can inject Botox in the face. It's absorbed by the trigeminal nerve, and you get decreased function of that sensory nerve. Of course, you'll also get some muscle weakness from the facial nerve, but it can decrease the pain from trigeminal neuralgia pretty effectively in some cases. Stellate ganglion block, sympathetic block to the head and upper arm can be a treatment for migraine, tension headaches, some facial pain. Sympathetic, just a quick review, is the fight or flight system, like the adrenaline system, which is in opposition to the parasympathetic rest and digest system, like the vagus nerve would be the big nerve there. They're in constant antagonism to each other. So usually you just do a nerve block here. You don't often use other techniques to elongate because it works pretty well on its own. A single injection can modulate the sympathetic nervous system relative to the parasympathetic for a couple weeks at a time. The kind of repeating can give you a couple months. So you got to think about it. Let's say they're always in 50-50. Let's say you do a nerve block of the sympathetic. Now it's still on, but let's say it's 48%. The parasympathetic is 52%. So the parasympathetic is just kind of barely winning, right? And so, and the other way around, right? So let's say maybe you start off in 52, so you're a little more sympathetic than parasympathetic, which would be normal in like a chronic pain state. So unless you work at it. So pretty low risk when done with ultrasound guidance. There is, of course, always a risk of increased pain in any of these injections. And you can try and elongate it by doing, and there is studies for this, doing pulsed radiofrequency or even ablating it with heat. And I guess in theory, you could do cryoablation, although I've never seen that. Spine pain. So I don't actually mention thoracic pain in this, but it does cover, it's the same pattern basically as the neck and the low back, which I'll discuss. So here's cervicogenic pain whiplash. So they took some healthy volunteers and used imaging and injected like saline into a facet. And then those volunteers said, oh, here's where I'm feeling the referral pain from the joint being swollen by fluid, put internal pressure on the joint. And so that's kind of what we use to say, okay, C2-3 facet, the top of the neck, can feel like pain in the back of the head, the top of the head, the ear, and right in front of the ear is the jaw. So it can feel like kind of facial pain there. It can feel like pain above and behind the eye, all from the top of the neck. As you go down a bit, it can go down into the traps, and you can see 5, 6, and even 7, 8 aren't there, but you can see, but it's as you go lower, it can feel like pain in the shoulder. It can feel like pain in the chest. It can feel like pain between the shoulder blades. So you can have pain in your shoulder, and it could be that you have like pain where your arm is meeting your shoulder, like in that little joint. It could have rotator cuff pain, could have myofascial pain, or it could be radiating from the cervical joints, the cervical facets. So you can see where diagnostic nerve blocks can help with this, right? Because if you just have shoulder pain, I can do a shoulder injection into the joint, local anesthetic, just a test of local anesthetic. And let's say minimal pain relief, some pain relief, but not that much. Okay, so it's not the joint. Now I can do an injection for the rotator cuff next, just a little bit up from there. You do or do not get relief. Let's say you've already gone through trigger point series, so I know it's not myofascial pain or the myofascial releases weren't giving any prolonged relief. And then we might move to the neck, right? Or maybe start at the neck, either way around. But so that's kind of the diagnostic injection. That's where they're useful for this. So in the spine, there's these little joints, facet joints in the back part of the spine. And there's a nerve that supplies feeling to that joint called the medial branch. So you can do a nerve block, diagnostic block for joint pain to these particular joints. Each joint has two nerves that provide feeling to it. So for any for any two joints, you do three nerves. So it's just temporary relief from a nerve block, 3 to 4 hours. And you just see how much relief you get from a given combination. You're kind of looking for 50%, ideally 80% gives you the best chance, but either way, even 50%, the chance of radiofrequency ablation helping the heat ablation is about 95% chance, 95% chance if the diagnostic blocks help enough. And then the radiofrequency benefit can last for, on average, a year. So that has the best evidence, has very large studies and meta-analyses of randomized controlled trials, and it has held up as an effective treatment for any kind of spine pain, radiofrequency ablation. Pulse radiofrequency is being compared directly to radiofrequency ablation. So doing the pulsing, which is the non-destructive form, so like that's kind of softer cousin of the heat ablation. And it can be as effective, but only to about 6 months, so a little bit less. So it's less painful, but doesn't last as long. You can try regenerative medicine. Prolo can be useful if it's kind of very widespread, bilateral. You have to be able to handle quite a few injections, so it's something you kind of build up to. Platelet-rich plasma is probably the least effective, like maybe 40–50% if you're injecting into the cervical facets. But if it does help, it lasts the longest because you've helped regenerate kind of the inside of the joint. So it tends to last 1.5 years, 2 years, maybe a bit longer. The studies just only followed the patients out for a certain amount of time and then stop following them. So PRP being something that might or might not help. It's kind of a coin toss, but if it does, it's really, really good. And I wanted to point out that if you have whiplash and you have migraines and you're getting Botox has been shown to be very helpful for the migraine portion, the head portion of that ongoing kind of pain area. But Botox is not a good treatment for the neck part of the pain. The best treatment is using either radiofrequency or pulse radiofrequency. Those have the best evidence of being the most effective. So like the difference is a lot of people with whiplash might see a neurologist who just knows how to do Botox. If you see me or interventional pain physician, what we can add to the care is doing these kind of spine interventions, which can provide longer lasting relief in ways that Botox just can't. And it's not just long lasting, it's about the intensity of the pain. You can actually treat it more effectively. So same thing for the lumbar facets. I'll go through the radiation pattern there. But again, lumbar pain, if it comes from facets, RFL has the best evidence. It's more risk versus pulse radiofrequency, as I said, but lasts about a year, as pulse radiofrequency tends to last something like 6 months. So you can, and the same kind of treatment options, you can try regenerative medicine, prolotherapy, or PRP here. And this is the referral pattern for lumbar facets. So you can see across the low back, it can go way down the leg, all the way to the calf. It can go, of course, in the back, the glutes, outside of the thigh, and even into the groin. You can see on the right there. So you can get abdominal pain from the joints in your back hurting. Sacroiliac joint is the very bottom joint of the spine, and all the same stuff. RFL is the best. Pulse radiofrequency. I have not seen a study comparing it in the sacroiliac joint, but I've done some pulse radiofrequency in the sacroiliac joints. Fine, it works about as you'd expect. And you can try, of course, prolotherapy or PRP. Referral pattern from the sacroiliac joint, the bottom joint of the spine. So you can see on the back on the right there, back pain, glute pain, outside the thigh pain. And then all the way down the leg, you can see all the way to the foot, ankle, calf, all the way to the toes. So I've had patients that come in, they think they have like a nerve being pinched, they have sciatic pain. And this is where the diagnostic injections can give you more information. We did an injection in the sacroiliac joint, and the numbness in their toes went away just for those couple hours, right? Because it's just a test injection, diagnostic injection, just local anesthetic. But we're able to differentiate using the injections sacroiliac pain from a nerve being pinched, which changes the treatment. Targeted physio instead of working on a radicular pain. Now they're working on radiating pain from a joint. So totally different. And you can see on the left there, that picture, you get abdominal pain, groin pain, front of the thigh pain as well. And what I always ask patients, because some people just have two reasons for pain, right? Some people, you do have something that I'll talk about in a second, radicular pain and spine pain, right, in the joints. So I always want to ask patients when I do these injections, how much it helps with pain, of course, like what's your 0 to 10 before the injection, what it is, 30 to 60 minutes after the injection, but also which pain doesn't help and which doesn't help, because usually people have kind of multiple areas of pain. So what pain is left afterwards is kind of what you want to know. Like, is there a possibly another reason for this pain in the area besides, of course, sensitization in the area? So another possible pain driver here, radicular pain versus spinal stenosis. So both of these are pressure from pain on the nerve. Radicular pain is when there's pressure on a single nerve, usually as it leaves the spine or somewhere within the spine. Something is pushing on the nerve, and then you feel pain down the leg. Spinal stenosis is when there's less room for basically the entire spinal cord. And so you get pressure kind of all over the spinal cord itself. And it can travel from the back into the hips, into the legs, or if it's in the neck, of course, down the arms to the hands. You can have numbness or tingling, muscle weakness. But the trick, of course, as I said, is telling radicular pain from radiating pain from the joints. So radicular pain is nerve irritation, radiation pain is from a joint. And the diagnostic injections are how we tell the difference between those. So epidural, just its own slide, because it's kind of something that's very common. Epidural steroid injection is is an injection where you do corticosteroid and local anesthetic, plus or minus, into the epidural space, the area outside the spinal cord, but within the spinal column. Right, so it's not in the cerebral spinal fluid itself. So it's not around the nerves. It's in a space that's in the spine, but not in that fluid. And this is actually one of the best treatments for radicular pain that we have from an interventional standpoint. If you're not going to do spinal cord stimulator, which very few people have access to, epidural steroids are actually pretty good. It can help with both radicular pain, or maybe you'd inject it right where the nerve leaves the spine. So put some steroid right there at the hole in the spine where the nerve comes out. So it can reduce edema and swelling in the area, take some pressure off the nerve and return some function, maybe help a bit with the pain, or inject it just in the whole epidural space and reduce some of the discomfort to the entire spine. And you can do this at all spinal levels, caudal, lumbar, thoracic, cervical, whatever it is. This is one of the few places, as I said, where I do actually regularly suggest steroid. Probably, there's anybody that has these kind of things needs to be seeing a neurosurgeon, because there are some kind of, we call it like a more minimally invasive surgery. They're just like smaller incision surgery, basically, where they can increase the space for the nerve as it leaves, or maybe take a little bit of the bone off the back of the spine, increase the space for the spinal cord. So if the cause of the pressure on the nerve is a disc that just came out of place, like recently, then there is an option for platelet-rich plasma in the epidural space. So taking that blood, spinning it down, concentrated platelets, and injecting that around that disc that came out of place can actually help reduce the size of the disc and take some of the pressure off the nerve. And when compared head-to-head to steroid, had about the same chance of being effective. So more than 50%, something like 80 to 90%, but PRP lasted longer for the reasons you can guess. Steroids decrease the healing in the area, so that the body's ability to heal the area. It does decrease pain, but you don't get to heal because you're putting something there that's kind of retarding that healing, as opposed to platelet-rich plasma, which increases the healing process. So it tends to last over a year and a half, 2 years, etc. I've had, if the pain has been around for a while, I've had a few patients that have wanted to try platelet-rich plasma epidural for pain that's been around for a while. So not a disc that just started being painful, but one that had been painful for a while. I let them know I do not know what the effect will be. I think it's a very safe injection. It's considered extremely safe because it's actually fights infection. So it's safer than steroid in that way. And it's actually helped some people, didn't help some. So I don't really know why. Sometimes we just don't know why until you do a good study. But it's kind of a last ditch effort to maybe like avoid surgery, basically. In the USA, of course, if you have radicular pain, spinal cord compression, you might get a spinal cord stimulator. It's very expensive. As I said previously, just not very accessible in Canada. And not always so useful, even if it was accessible. They're probably overplaced in the US. So peripheral joints. So this is just a general picture of a synovial joint, which is a joint that has fluid in it. And those are the ones that are kind of the big joints in your body. So knee, hip, ankle, shoulder, as well as kind of the joints in your finger. So the thumb, like the base of the thumb, would be a pretty common place for osteoarthritis. So the pain from a painful joint happens from the structures within the joint capsule itself. So there's the bones meet, they're capped by cartilage. And then what attaches the bones to each other is the capsule. So like it's ligaments, basically kind of attaching bone to bone. And then there's a synovial membrane, which creates the synovial fluid, which has that hyaluronic acid in it. So that's just the general, like any synovial joint, they take different forms, but that's just the general makeup. So I'm only going to talk about one of those joints because there's just too many. And it's kind of similar for all the big joints. So let's look at the knee, for instance. Let's say you need to know, is it knee pain? Can be due to a lot of things, but what's actually hurting is the question. You can look at that. There's multiple bones there, 4 bones in the knee, patella, which is like your kneecap, the femur, your thigh bone, and 2 bones in your lower leg, tibia and fibula, right? And so there's the patella interacting with the femur interacts with the tibia, and the tibia, there's a whole nother joint to the side of your knee where the tibia and fibula touch each other, right? So, and then there's a whole bunch of, and each of those joints has ligaments that connect them to each other. And of course, the big joint has the fluid in it. And then there's a bunch of muscles in the area. Especially in the knee, there's tons of muscles there. So with their corresponding tendons that attaching them to the bone. So you need to figure out if it's knee pain, is it intra-articular? So put a little local inside the joint itself and see, does that turn down the pain? Like, is it the structures from within the joint, or is it external structures to the joint? And of course, even if it is internal pain, once you know that, then can you by blocking the sensory nerves to the joint? Can you turn the pain down as well? Because all those, depending on what works, that changes the treatment options. If it's intra-articular, you do a diagnostic intra-articular in the joint injection of local anesthetic. Then you can inject things into the joint to treat it, because now you've diagnosed the knee joint itself as being painful. So within the joint, you can put Botox. That's a totally private pay thing, but I've had pretty good success for patients that can afford it. Regenerative medicine, prolotherapy or PRP, good evidence for both of those, PRP being more effective than prolotherapy in all the studies, basically. Hyaluronic acid or steroid, all those things can be useful, right? And then of course, if it's external structures to the joint, you can use regenerative medicine to try and help the healing of any ligaments or tendons in the area. If you get good results with diagnostic injections to the sensory nerves to the joints, you can do nerve ablations to treat joint pain. So same thing for the spine. We use those RFL needles, where you can either do heat destruction, you can do pulsed radiofrequency, or you can do cryoablation. Heat being the most painful in general, pulse radiofrequency being very much not painful, but lowest risk, also lowest chance of helping, although chance is still pretty good, versus cryoablation, which is kind of a newer technique, so it's more expensive, but is the least painful, second most painful, not as painful as the heat. If you've had a knee replacement and you have chronic pain in the area where your knee's been replaced, you can't put needles into your joint anymore because now there's a risk of infection. If somebody comes in with the needle into the joint capsule, it can seed the metal, and then it's very difficult to treat. You can, but sometimes it results in needing a whole nother surgery if that metal gets seeded with infection. So basically, I won't inject in there anyway. I'll let the surgeons can inject into their own surgeries if they want to. Most people don't like to. The best treatment for post knee replacement chronic pain in that area is to do nerve ablations. Same holds for shoulder, hip. Let's say for thumbs, they're just starting to do the anatomical studies on thumbs. So that has, they just published the anatomical study. So we don't know how to do ablations there yet, but you can put things into the joint. So you can put steroid, which can be effective, but again, degrades the joint. You can put hyaluronic acid in theory, Botox in theory, but definitely PRP or prolotherapy have a pretty good effect. Nerve pain. So pain caused by damage to or dysfunction of a nerve. So we've already talked about some of that, like in terms of a radicular pain or spinal stenosis, that's just centrally caused neuropathic pain. But you can get this like if you have something like occipital neuralgia, pudendal neuralgia, entrapment of some kind, so like carpal tunnel for the wrist. People have like ulnar nerve entrapment. Neuropathic pain feels burning, tingling, shooting, electric, numb. A lot of times for neuropathic pain, you can't do RFL for most of this because the nerves there's too much increased pain risk afterwards. Steroids, it's what most doctors know. It's been around for a long time, widely available and cheap, and can be effective. But it also depends where the nerve is and what's going on with the patient. So like, for instance, if you have diabetic peripheral neuropathy, normally you would try to avoid steroid because steroid raises your blood sugar. So maybe in that case, you would use dextrose or try something like pulsed radiofrequency to modulate the nerves. For something like pudendal or occipital neuralgia, steroids can be helpful for a couple months at a time. Pulsed radiofrequency lasts longer, cryo works better, less side effects. But for instance, you can't do cryoablation or radiofrequency ablation with heat on radicular pain for pain down the leg. So then, or anything that has a lot of motor function where you were dependent on it, like the ability to walk or move your arm. So where the nerve is, which nerve it is, what the surrounding structures are, all helps decide which of these interventions can be applied for any kind of neuropathic pain. But usually you do still follow the same process of diagnostic injection. Is it possible to turn the pain off for a little while? Hopefully. And then what do you do to treat that area? My preference over steroids is usually dextrose, like perineural dextrose, subcutaneous dextrose, some kind of hydrodissection, if it's the nerve entrapment, or of course, epidural dextrose. And for all other pain areas I didn't cover, like pelvic pain, I didn't cover abdominal pain, stuff like that. All pain is carried by nerves. It's not necessarily neuropathic pain, but the signal of pain is carried by a nerve. And so you can still go through the process, have a diagnostic injection. Can you turn the pain off? Which nerve is carrying the pain? And then that can help with other people who are treating you, massage therapists, acupuncturists, physiotherapists, etc. It can also help you avoid other things. Like people that have abdominal pain, there's a thing called ACNES, anterior cutaneous nerve entrapment syndrome, where a nerve gets entrapped in the abdominal wall, not the viscera, right? But what people feel is stomach pain. And so you go to your doctor, you say, my stomach hurts. Maybe they send you for imaging, can't find anything. They do some blood work, nothing's there. You send you to a GI doctor because your stomach hurts. So they do an endoscopy and a colonoscopy because, that's their hammer. And so they don't find anything. And then, I would see a patient with that who's had this full little workup and do an injection of local anesthetic in their stomach wall, and that turns off the pain. Right. So it's not because I'm so much smarter than everyone. It's just I have just a different set of tools that I can use. There's usually, even if it's visceral pain, there's usually a nerve that we can inject to kind of turn it off to help know where the pain is coming from. And sometimes those nerve blocks are useful as treatments. And I just want to say, in general, for kind of people that are very sensitized, these are the two injections that I have found to be fairly useful because they can be kind of titrated up. So dextrose caudal epidural is just dextrose or sugar in the epidural space. We inject it in the sacrum. It's not using a huge big needle like epidurals, like for labor, or like when you see in the movies where they use those like big whale of a needle. This is good for pain in the pelvis, back, hips, legs, feet. Generally just kind of good because dextrose can be very calming. Repeated injections can be desensitizing, and you can titrate the epidurals. So I've had a couple patients where I've gone through the process of using like a 30 gauge needle, very small, and injecting 1 cc of dextrose and doing that a couple times, going up to 2 cc's, 3 cc's, working our way up to 10 cc's, which you can get the entire sacrum, right? So it's people that have like low back pain, maybe it's radiating down the legs, and we're just trying to modulate the sensory nerves, the bottom part of the spine. I don't know exactly always what's wrong, but the pain is in the low back, down the legs somewhere, right? And so dextrose has basically no systemic side effects. I have patients that have type 1 diabetes and are always wearing their continuous glucose monitors. The glucose doesn't go up. So it really just has no real systemic effects. It's like eating like a half piece of candy or something. But it can be effective at kind of desensitizing that whole area. Greater occipital nerve block is kind of good for basically, it's on the back of the head. It can treat head pain, face pain, neck pain, trapezial pain. And for whatever reason, blocking that nerve, similar to doing dextrose in the epidural space, but blocking the greater occipital nerve has been shown in a couple different studies to be able to reduce pain for a couple of weeks at a time. Again, it's a bit harder to titrate the dose, but if it's basically, you can come with bad pain, you just kind of have the block a few times, and that can, as long as you do it somewhat regularly, it can be helpful. Again, not for everybody. There's always risk of increased pain with these things. They're not risk-free. You can't just be like cavalier with them. But if you have quite bad pain, you can't handle maybe injecting on the spine, but you still want to treat the pain. These can be kind of mitigating injections, basically. So just to go through kind of how maybe I think about it a little bit, say I had a 45-year-old, had MBA 3 years ago, has neck pain, headaches, also low back pain going down the back of the leg to the right. Sleep is also an issue. Low mood is an issue. So I'd see them for history, do a physical exam, look at the imaging, and I want to say that because imaging doesn't show pain. It can show some degeneration, and sometimes it shows what could be the painful thing. But I have a lot of patients come in, oh, I got these discs out of place and I got back pain. What really tells you pain is the diagnostic injections. They're much more specific, right? They did very big studies looking at imaging versus where pain was confirmed by injection, and it does not match up. The radiologists are unable to tell based on the amount of degeneration or pressure on a nerve, what it looks like, that kind of thing, or even tears in connective tissue like rotator cuff. If you see like a tear on the rotator cuff, it's not necessarily that's causing the pain that you have. So imaging is useful, especially if something just happened, like you just had an accident and now it hurts. It's useful. Chronic pain, less so. I would ask the patient, what has worked so far, what hasn't? So like, have they gone through some meds, make sure nothing has worked. And of course, my first step is rarely going to be to try like a fifth or sixth medication. I try something else. If all those other meds haven't worked, meds probably aren't going to be the only answer or the ongoing answer. Of course, ask what they've done, what other practitioners they've seen, physiotherapy, counseling, make sure they're kind of covering the bases in terms of all the things that can be inputs to chronic pain, like mental health. I would see some patients that have had pain for a couple of years and nothing has been tried. So certainly I wouldn't want to miss something. So if nothing's been tried medication wise, then maybe I'll try something just to see if it does help. I recommend group medical visits for patients. So if they have a lot of central sensitization, of course, central sensitization group medical visits. We have a lot of ones on pain, self-management, movement things. There's some for sleep. And of course, considering supplements that can help with sleep, like magnesium. I'm sure everyone here is taking magnesium. You can refer a counselor for mental health. So if you don't have coverage, there's a group medical visit for CBT on pathways in BC, which is a good resource. And then start with kind of what hurts. What's holding the person back from functioning optimally? What's holding them back the most from that? Let's say, usually people say headaches in this case. So let's say they have like chronic migraines, 28 migraines per month, neck pain goes into the upper extremity and pain, and they have facial pain and jaw pain as well. So let's say they've already tried a couple meds, so we consider Botox. Always takes time to get approval, but it can also help. It can help both the headaches and the TMJ pain. So that's a good kind of getting both for one. You can also try the CGRP inhibitors, which the province will cover for chronic migraines. And they'll actually cover it for if you have at least 4 migraines per month. The CGRP inhibitors will be covered. So for neck pain, maybe try some diagnostic injections for facet pain, and if positive, schedule for radiofrequency ablation or pulse radiofrequency. And in the meantime, try some treatment nerve blocks. So like see if a greater occipital nerve block, maybe combination greater occipital with trigeminal blocks are helpful. If the ones on the face are not helpful enough, then going a bit deeper and doing this phenopalatin block. And if all those don't help, then oftentimes I'll combine them with a stellate ganglion block. Say that we've kind of optimized the head. We have a plan for the head, neck pain, etc. And we go to the low back, maybe, based on physical exam, but start with either lumbar or sacroiliac, because joint pain is the most common. Maybe try a combination of both. So maybe they have both lumbar facet pain and sacroiliac pain. Basically just looking for a combination of injections that gives me at least 50% decrease in pain, optimally 80%. And then RFL would be the first choice for spine pain, any kind of spine pain. If they're very sensitized, maybe I'd consider pulse radiofrequency. Some patients just cannot, it's just very obvious that they're not going to be able to handle the heat ablation. And in the meantime, maybe try a series of dextrose epidurals combined with the nerve blocks, maybe 3 or 4 of those. And for some people, that can desensitize the area a bit and keep things a bit more functional. And if it's not, the joints in the spine can be radicular, so try a diagnostic nerve root block next. Just local anesthetic around the nerve root. If it helps, try steroid or pulse radiofrequency. Again, a series of dextrose collar epidurals, which just helps so many different things. And consider steroid or platelet-rich plasma epidural. And of course, this patient usually would have also, some numbness in the foot and knee pain and maybe hip pain. So you kind of work your way through each thing as you go. Well, that was a lot. Any questions?
Questions are in the Q&A.
Oh, yeah, right. So I'll just start at the top here. All right, so for stellate ganglion block, for someone that has CFS, how frequent would you recommend treatments? Allergies to lidocaine, so bupivacaine on its own, yeah, fair enough. There's no real evidence. Basically, just try one side then the other, like on a different day, right then left, or left and right, whatever, and then just see, does it help? If it does, for how long? And then get it again when you need it, or if it doesn't help, try again within like a couple of months. See if it does help. Is there a clinic similar to Change Pain Victoria? Yeah, there's a couple of clinics there. There's one that's like a like a private clinic like this, like a community clinic, as opposed to the healthcare authority. And this person says they have 2 total knee replacements, went to rehab, but still experienced very bad pain in the muscle and tendon that were cut during the surgeries. Yeah, so for that, so for instance, if you got knee pain after knee replacements, you got to try the it's just surrounding the joint. As I said, joint pain can feel like muscle pain, right? So you can try some diagnostic nerve blocks to the joint and see if that turns off the pain from that joint, what's in the joint capsule, so you can do an ablation process, nerve ablation there. Can dry needling or block be good for dental or facial pain? Yep. I think, there's nerves there, there's little muscles there. Dr. Gunn, I think came up with, what did he come up with? The gun technique or whatever. Yeah, I don't remember. There's some people here that I know did that training. He's a pioneer. Yeah, so you can try all that stuff. I think there's only one way to find out. You got to try it. I think the risk in the right hands with a tiny little needle is pretty low. Trigger points, what are the risks of not using ultrasound guided for trigger points? As long as someone knows what they're doing, the risk of with trigger points is very, very small. I guess you can hit the lung if you don't know what you're doing, or like blood vessels, you get like a little hematoma or bruise. So yeah, trigger points, you just gotta put the needle in, see if you hit it. Can you use hyaluronic acid in your sciatic area? Hyaluronic acid basically should save for joints because it's quite expensive to use in soft tissue when you're not quite sure what's helping. Anyway, you go through the process. Diagnostic injections. Is it actually coming from your sciatic nerve, or is it a joint, or is it soft tissue? Those are the kind of questions you got to ask. And then if it's a joint, hyaluronic acid is a good option. Botox for tension headaches. Yeah, it can be helpful. It's getting it covered that's the problem. Using Botox for tension headaches. I've never seen like a insurer that will cover it, so that would have to be like a private pay thing. How long does it take to get an appointment for an interventional treatment? Do you need a referral? I do not know what our wait list is right now, several months. And yes, you need a referral from a GP to specialist. I think that's, yeah, it's very standard. We also have a process at Change Pain Anyway, where if you take some of our group medical visits, then you become a patient of that doctor and they can refer you into the clinic, even if you don't have a GP, just because so many people don't have GPs. We try to make it a bit more accessible. So you have to take a group medical visit at Change Pain and then contact the reception and say, I took a group medical visit. I'd like to be seen by a doctor. If Prolo helps short term, are there issues in the long term? Not that I know of. Like the whole point of using prolotherapy is that it causes inflammation in the area, which increases healing and can desensitize the pain nerves because it's such a strong dextrose. But it's not going to cause weakness. I don't think there's any long-term studies, but generally just getting high concentration of sugar into an area. And we know what all the short-term effects are. It's not a steroid. There's no all those systemic side effects. Probably it's pretty safe, be my guess, about the Prolo and the SI. So the balance between things that increase inflammation, like PRP or Prolo, versus the general approach of trying to reduce inflammation with chronic conditions. Yeah, I think it's about how targeted the inflammation is and the systemic spread. So like you're not going to get a lot of systemic spread of the inflammation that's induced by these targeted interventions. If you get an injection if you get prolotherapy all the way down your spine, probably going to overdo it. and have some issues. So, you know, generally the answer is start low and go slow with these things. You would never jump into doing, you know, 50 injections of prolotherapy. You would try tiny little bits at a time, see how much it helps, and see if you can titrate up or if it's too much for you. Right. So it's never all or nothing with these things. Clinic in Surrey, Langley, or Delta, where you can get trigger point injections. Muscle MD has a lot of people that do basically just all trigger points.
So Muscle MD has closed their Surrey office.
Thanks. Right, so now I don't know. Sorry. Recommend for rotator cuff pain. Do you know the answer to that then, Rick? Do you know any other clinics in Surrey, Langley, Delta?
No, we're trying to find something, but right now it's a bit of a loss, unfortunately.
Rotator cuff pain, chronic ulnar nerve inflammation, or elbow bursitis. Yeah. I mean, generally, if it's soft tissue, then the regenerative medicine is good. I assume people with rotator cuff pain probably had a steroid injection at some point. So they could try that and see if it helps you rehab a bit. Chronic ulnar nerve inflammation or elbow bursitis. Again, if it's bursitis, a small dose of steroid, of course, you have to combine all these injections with like appropriate physical therapy and movement. Ulnar nerve inflammation from an interventional standpoint, anyway, you can try just repeated hydrodissection with dextrose. So treatments for tendinitis, yeah, same thing as any kind of soft tissue. So prolotherapy or PRP can be good. If it just happens, sometimes people will use steroid. Like if you're, you know, a 25-year-old who tears a small tendon and you're going to be able to rehab it, you're not going to weaken it because it's still super strong. If you're a 75-year-old and you tear a tendon, you know, your chance of rehabbing it and actually getting it stronger are lower. So then you probably want to avoid something like steroid in the area. You know, so it matters on the patient. Yeah. So someone asked trigger point injections, normal saline versus lidocaine show similar results. I think it depends on where you're injecting. Yeah. So like for headache, local anesthetic in the trigger point injection is more effective. Botox can be effective too there. You know, if you got, I don't know, if you got, you know, up and down your back, some stiffness, maybe in your stomach, that kind of thing. I've never seen any studies on it. I like to use local anesthetic because of the anti-inflammatory effect. But that's just an argument I've made in my own head, not because I've seen studies. What type of treatment can be done for sciatic nerve pain? So you got to figure out what sciatic nerve pain is. The sciatic nerve is a big nerve. It's like it's like 5 or 6 different nerves out of your spine that all form into the sciatic nerve and then go down your leg. But sciatic pain in the distribution of the sciatic nerve, like down the back of your leg, going back to that kind of spine pain picture, can come from the facets. It can come from the sacroiliac joint or both. So it can be the joints in the back of the leg, or it can be pain from one particular nerve getting pinched. And so you'd have to treat that particular nerve, or it can become, you know, there's a couple other things, like it can get entrapped for some people in the piriformis. There's like things that mimic all those, like superior cluneal neuralgia can cause pain down the leg. So really you have to go through the process of finding out what's actually hurting. Like it's rarely the sciatic nerve itself. It's usually one of the nerves that forms the sciatic nerve that's getting pinched somewhere, or it's radiating pain in the area of the sciatic nerve from one of the joints of the back. Does prolotherapy heal tissue or nerves? So prolotherapy is basically just injecting dextrose at too high a concentration. It causes irritation, right? Which we use in soft tissue. You can't use like 25% dextrose around a nerve because it will just cause inflammation of the nerve, just hurt. It doesn't destroy it or obliterate the nerve still there. It just kind of causes inflammation in the area that the body has to heal from. So you can use that to your advantage by doing it in soft tissue. And certainly around a nerve, you could use less than 10%, usually something like 5%, and that can be kind of more calming to a nerve, a sensory nerve especially. Oh, sorry, PRP. PRP doesn't do any destroying or obliterating. It just, you're basically just injecting growth factors and healing factors into the area. So it doesn't do anything to nerves, as far as I know. And someone says, yeah, and anybody can make an appointment with any of our doctors. Just ask the doctor that you're seeing for like a second opinion from another doctor. Does oral hyaluronic acid taken orally support connective tissue collagen? So collagen taken orally can support collagen. Most proteins taken orally, which is probably because if it has like high glycine, but most proteins taken orally just are broken down and turned into like amino acids. So yeah, I mean, getting enough amino acids can help. I don't really know about trochanteric bursitis nerve pain. So it's either like it's bursitis, which is like a little fluid-filled sac causing pain, or it can be, I guess, nerve pain in the area. I'm not quite sure which one it is there, but generally, if you have something like trochanteric bursitis, that feels like pain on the outside of the hip, which can be due to dysfunction in the muscles. It can be a nerve that's entrapped that's causing pain in the area. Again, that can be radiating down from the back. I don't obviously know your case, but generally, I don't really think oral hyaluronic acid is that effective. Someone's asking, what's the treatment for patients' history of recurrent meningitis? So certainly you're not going to get meningitis or because of the treatments that we get. I think that's the question. But if you're having some pain on the outside of the head, certainly you could try some of these nerve blocks. And most of the nerve blocks are under ultrasound. There's a couple that are just by palpation. That's not that common, at least in my practice. And if you're getting kind of lightning bolt episodes in the back of the head, so that might just be like an occipital neuralgia of some sort. There's a couple of occipital nerves back there. So I'd have to kind of talk to you a bit more. But yeah, you could try nerve blocks under ultrasound. Okay, for migraines specifically, generally preferred to do like interventions or medications. There's no like evidence that one is better than the other. Some people just prefer or have better effect with one versus the other. To my mind, if you can take a pill a day and it has minimal side effects, then that's probably an easier thing to do, like for the next 5 years. Less time out of your day, assuming minimal side effects, of course, less risk. But for some people, they just don't want to take a pill. They want to do something else. And sometimes the migraines are caused by something else. And so maybe they won't necessarily be treated by a pill, like cervicogenic migraines, much more difficult to treat with preventative type meds. So like whiplash is harder to treat with meds. It's better treated with interventions. So it sort of depends on the reason for the migraine. Is it primary migraine or secondary? And then I think you should at least try 1 or 2 classes of meds and see if they help you. And then if they don't, or if you just prefer, then you can try interventions and sometimes they'll be helpful. We support patients dealing with WorkSafe. Yeah, we see a lot of WorkSafe patients. And we chart. We explain in the chart how pain is related to the injury itself. Yeah, just for the things that are covered. Certainly, you always have to talk about the mechanism there so that WorkSafe will pay attention to you. So someone asked for stellate ganglion blocks. How does it work so that the parasympathetic system is not blocked as well? It's because they just run in different areas. So you're blocking the stellate ganglion block, which is where the sympathetic nervous system is, that the sympathetic nerve is in that area. But the parasympathetic nerve, the vagus, is not in that area. So it's not affected by the block. It's the long and short of it. Can people get treated for many areas at once? That's kind of between you and your doctor. I can often, once I get to know patients, like once we've done appropriate diagnostic injections, so I know I do an injection just one day, just on your SI. I know it's your SI. We know that you get, let's say, more than 50% relief. You're happy with that in that area. Then, and you also have, let's say, cervical spine pain, and we've done our appropriate diagnostic injections, only that on that day. Then, if we're doing treatment, like injections as a treatment, then you can do multiple areas on the day. But it also just depends on the doctor. Some people are more comfortable with that. I'm happy to do that usually. But also just depends on the patient, right? How much do diagnostic nerve blocks cost? They're MSP covered. We cover the local anesthetic. Certainly you go to some pain clinics that charge, some don't, sort of depends on the clinic. We choose not to. For the cervical branch blocks, the pulsing thing. Oh yeah, so you use local anesthetic and then you do the pulsing. Otherwise it would make your neck twitch a bit. It would just feel weird. Yeah, so there's usually local anesthetic is involved somewhere in what I do, unless it's just a dextrose injection. I'm gonna ask, after years of successful trigger points, nerve blocks, my body flares up after any mild treatment. Why is that, and how can I get relief? I can't rely on trigger points anymore. That's a very big question. I don't feel like I can adequately answer that here. I would have to find out like what has changed, what you could change back, diet, exercise, something in your life. Otherwise, hormones can change. You got to kind of look at those things. That's a very big question. Are nerve blocks contraindicated in patients with pacemakers? None of these blocks are contraindicated in patients with a pacemaker. Some of the other procedures can be contraindicated in pacemaker treatments, like using the radiofrequency ablation. You got to be careful where you put the grounding pad, stuff like that. I think more about, if you got a pacemaker, are you on blood thinners? And that can be a contraindication to certain kinds of nerve blocks. And someone asked what intervention was most effective for ankylosing spondylitis. So assuming it's SI pain, I have a couple of patients with ankylosing spondylitis, so just doing serial injections. I've had some good effect with prolotherapy. Of course, doing steroid into the joints for the stiffness, really useful, and then doing radiofrequency ablation. I got a couple of patients who I've done that. I was doing steroids every 3 months. We talked to their rheumatologist and then proceeded with radiofrequency ablation, just making sure we had the okay there. They didn't care, as it turns out. So now I've just stopped asking. And the radiofrequency ablation to the SI joints relieved vast majority of the pain. And we've gotten down to, I can think of one patient I just saw him the other day, where instead of doing steroids every 3 months, we do them every about 9 months or so. No, I don't know any neurosurgeons in Canada that work with that. Good thing, I'm sorry. Ongoing wrist and elbow pain. It just depends on kind of what is the cause of it. You got to remember, it feels like wrist and elbow pain, could be one nerve causing all that, being entrapped up higher. Could be pain kind of radiating, from the thumb into the wrist. It could be carpal tunnel. Carpal tunnel can go all the way back up the arm, even though the median nerve is entrapped at the wrist itself. So it sort of depends on where the area, like what the pain is. It's a bit broad for me to be more specific, sorry. How can you arrange a referral? GP, walk-in clinic, or as I said, you can take any of our group medical visits and then call the reception or email the reception and ask to have a referral. Dr. So I know it's 5. I don't know if you got time limit on this.
Yeah, we do. Thank you
Yeah.
for a fantastic presentation. I'm hoping that we can have you back in the spring. Have a great weekend.
Thank you for having me. Thanks, everyone.